All right. Good morning, good afternoon to around the world. A warm welcome to our webinar autumn session today, which is a little special as I'm in Budapest right now. We as North Medical have attended the ESWOC conference here during the last days, and that is why I'm still here today and also with some fetal CMR users. For example, next to me is sitting Manuela Tavares de Souza. She's from Hamburg, UKE, from Eppendorf, and also using SmartSync since long time.
The beginning.
Right. So it's great that we are together here. And of course, we dedicate this webinar to the topic of fetal cardiac MRI again. So this webinar will be recorded and I will send around the recording link afterwards. It's myself and Fabian that will lead you through this session today. And for those of you that might attend our webinar for the first time, I would like to highlight that it is our aim to build a community and to offer a platform for networking and exchange. We have now more than 80 SmartSync devices in the market around the whole world, mostly in America and in Europe, but there are some in China as well, Israel, and yeah, it's growing. You are all very welcome to talk and to discuss during this webinar, and please raise your finger to show us that you want to speak. Paste your questions directly into the chat or also use the Q&A function. Before we start, just a brief review to our last webinar session, which was in the summer. Some of you might remember that I have asked whether you would be interested in a forum to exchange about fetal cardiac MRI. And there were about 80% that answered the poll with yes. And as this is a very clear result for me or for us that you are interested in a forum, we have created one for you. The aim for this forum is to build an official platform for the fetal cardiac MR community to connect and to exchange on various topics. And this is how you can enter the forum. You go to our website, north.de. You have first to sign up, then we will accept your signature, your signature, and you can then log in on our homepage. You click on Forum to see the latest posts and on Members to discover other members of the fetal CMR community. You are also, or it's also possible to allow other forum members to view your profile so that you can, or they can follow you, which is great, I think. And this is how the forum looks like. We have 5 different categories defined. The first one is fetal cardiac MRI, so just in general questions or discussions you want to raise. Then there's one section for clinical cases that you maybe want to share, one for application of SmartSync, for challenges of the clinical workflow, and the last section is for the slice-to-volume reconstruction platform. You have the possibility to create your own post, of course. You have the possibility to follow other members. So it's a member area, and you are able to like, comment, and share other members' posts in this forum. You can edit your own notification settings, and you also get notified if you want to when people you are following post something new. So this as information for you. Do you want to say something, Fagan? No. This as information for you, and please feel free to create your first post. Would be great. One more information or news for you. We have also developed a training platform on our website, and this is intended for those SmartSync users that have already participated in our basic safety and function training. So for those who already use SmartSync. And why did we do that? It is because we know that the scanning can be challenging in some cases. And of course, we want you to optimize the process to get the best reliable signal and image quality. And therefore, we have created some learning training videos that are now accessible on our website. And you just go to the members area again, click on trainings, and then you will find it. It's 3 sections there. The first one, how to set up SmartSync. This is already online available. There are, I think, about 7 videos from that you can learn. And the second and the third section, how to plan sequences and how to adapt sequences, is not yet online, but will be online soon. All right, and now let's focus on our autumn session today. The title is Why an Additional Fetal Cardiac MRI Can Be So Important. Specific case studies will be shown. And I think the session today is especially interesting because that is exactly where we aim to go in the future, to use fetal CMR as an additional diagnostic tool. Yeah, and therefore we need first to know for which clinical cases CMR has beneficial value. And I think this is exactly what we will learn today. Short reminder, we had 3 sessions already this year. They are online. The recording is online available. And yeah, there will be another session, but I will announce that later again. All right, our expert today. I'm very glad to welcome 4 speakers. The first one is Michelle Odin. She will start today. Michelle is from Children's National Hospital, Washington, USA. Michelle is pediatric and fetal cardiologist. And I'm very happy to hand over to you, Michelle.
Thanks so much. All right, you can see my slides?
Yes, perfect.
Okay, awesome. So, hi everyone, my name is Michelle Udine. Like Heidi said, I'm a fetal and advanced imaging cardiologist here at Children's National in Washington, D.C. And today I'm going to present a case of a fetus with a dilated left atrium. So this is a 33-year-old G1P0 that was referred due to a dilated left atrium. And this was at 30 weeks gestation, focusing on the first fetal echo. And so this is the 4-chamber view, levocardia, and this is left and this is right. And you note that the left atrium does appear generous in size. Moving to our next clip, this is more superior in the 3-vessel trachea view. And you note that this is the right superior vena cava, and the red jet is the innominate vein entering the right superior vena cava, which is normal. The vessels do appear somewhat prominent. And then we have a normal aortic arch and a normal ductal arch. This is our sagittal view. The spine is posterior and sternum is anterior. There's an unobstructed aortic arch and an open foramen ovale with normal right to left flow. And so when presented as a cardiologist with these findings of a dilated left atrium and or a dilated right superior vena cava, there's a lot of potential differential diagnoses here. One thing in particular that we were concerned about was the potential for a vascular abnormality, a potential AVM that would be causing increased blood flow to the SVC. This patient came back for follow-up at 34 weeks, and it was noted that there was worsening left atrial and ventricular dilation and worsening dilation of the innominate vein and right SVC. And this time the atrial septum appeared intact, which was a change from the prior study. And there was a suspicion that there may be a systemic venous anomaly. And so we went ahead and did a fetal CMR at 35 weeks on our 1.5 Tesla Siemens scanner and did cine imaging with the North Medical Doppler ultrasound device for cardiac gating. These were our sequence parameters. So just focusing on our first cine image in the axial plane. So again, this is right and this is left. And you'll note how dilated the left atrium appears. And if you focus on the leftward aspect of the atrial septum and following that superiorly, the right superior vena cava actually enters on the leftward aspect of the atrial septum into the left atrium. Also in this view, the atrial septum does appear like it is likely intact, and there is left ventricular dilation as well. This is up superiorly in the 3-vessel view, and again noted the dilated innominate vein. The right superior vena cava is in the normal position in this view, and the aortic arch and ductal arch are normal. This is a nice coronal image of the defect. And so this is the SVC that enters directly into the left atrium. This is mitral valve and left ventricle. Important to rule out potential mitral valve or aortic valve abnormalities. And so this is a 3-chamber view. The mitral valve appears normal with no regurgitation, and there is an unobstructed left ventricular outflow tract. The gating worked very well in this case, and the other thing we wanted to focus on was the ventricular function, which looks normal in both ventricles. We worked with our radiology colleagues to look at the neck and brain to rule out a potential AVM. And so this is within the neck, and you'll note that there's bilateral internal jugular vein dilation. And in the brain, there was a dilated tortuous sigmoid sinus. There was no evidence of an AVM. And so the diagnosis, which is very rare, is a right SVC to the left atrium with an intact atrial septum and dilation of these structures. The cause of the venous system dilation was somewhat elusive. There was a lot of different potential etiologies for that, but these findings together made us concerned about the physiological consequences after birth with the intact atrial septum and what would happen to the baby during transition. And so the delivery plan for the baby was, for the mom, was to be induced at 39 weeks, and we facilitated transfer to the ICU with a cath team available in case the baby experienced severe hypoxia for a potential balloon atrial septostomy, which would facilitate mixing. The pregnancy was complicated by IUGR, so she was induced at 38 and 5 with a C-section due to fetal decelerations. The APGARs in the delivery room were 6 and 8, and the baby was intubated for hypoxia and required oxygen to maintain saturations. So these are just a couple of clips from the postnatal echo, which are consistent. And this is a clip from a postnatal cardiac MRI, which was a pheromoxetol enhanced study. And this is our 40 flow whole heart sequence. And the MRI showed a QP to QS that was 0.4 to 1 and normal SVC flow. The pulmonary blood flow was reduced with small pulmonary arteries and veins. There, again, was no AVM in the brain or neck. Clinically, this baby remained persistently hypoxic, but was not in any respiratory distress and was hemodynamically stable. So the baby underwent a modified Worden procedure at 2 weeks of age, a surgical procedure, and was discharged home within a week and did very well. So I think in conclusion, fetal CMR can be used during the 3rd trimester to help diagnose systemic venous anomalies, and it's helpful when echo imaging is technically difficult, or in this case, to further define the anatomy. And the axial cine stack can show the SVC course that enters into the leftward aspect of the atrial septum. And this is a rare diagnosis that requires transfer to a tertiary care center that can perform neonatal cardiac surgery. That's it. I just want to thank all of you, and then Dr. Trong, our MRI director, Dr. D'Onofrio, our fetal cardiology director, and Dr. Bulis, our radiology director here at Children's National. Thanks, everyone.
Thank you, Michelle, for this very nice case. Are there any questions? Right now, I didn't see any questions in the chat, so if you have any, please write them in the chat. I have one question, Michelle. So you have shown us the delivery planning of this special case. Without this cardiac MR, how would the delivery planning or the whole management after birth would have changed? Is there drastic changes?
I think this made us feel more confident that we needed to change the delivery plan for the patient to be transferred right away to us. You know, the first thing was ruling out a potential AVM. But then since we were more confident in the diagnosis, to say that we think that this baby might be hypoxic after birth. And so I think instead of doing imaging, let's say at an outside hospital where they deliver and letting the baby hang out there for a while, this kind of made us expedite the transport with our center.
Nice. Yeah, very good. All right. If there are no other questions, I will just go further. And in order to welcome our second speaker, I'm just sharing my slide again. Sorry. Yes, that's the correct slide. So the second speaker today is Julian Lütgens. He's from University Hospital Bonn in Germany. Julian is radiologist and director of radiology department there. And yeah, Julian is one of our first users of SmartSync, and he has, I think, now 3 or 4 years of fetal CMR experience. So I'm very happy also about this collaboration and to welcome Julian today.
Yeah,
and you can share your slides, Julian. Yes.
For your kind introduction. So hello everybody here in the webinar. So I first want to draw your attention to a article of our group, which we published in Radiology Cardiothoracic Imaging, which is a review about fetal cardiac MRI using Doppler ultrasound gating. And we did this together also with Malenka Bissell from Leeds and Alex Barker from Colorado's Children. And if you start with fetal CMR using Doppler ultrasound gating, I think this review is very nice because it shows you how everything works, what kind of sequences you can perform during your fetal cardiac MRI. And it also shows you how to plan a fetal cardiac MRI, and also gives you insights into more advanced techniques like 4D flow, which can also help to figure out the proper diagnosis. And just like a few days ago, we published another paper, which I also want to draw your attention to. It's about myocardial strain analysis in congenital heart disease with fetal cardiac MRI. And there we also analyzed different fetuses with congenital heart disease. And what we found there, which is quite interesting, that the myocardial strain is influenced by the congenital heart disease. And it might be possible to differentiate different congenital heart diseases with strains. So you have a hypercontractility in, for example, a coarctation of the aorta, and you also have like lower left ventricular globus stain, for example, in hypoplastic left heart syndrome. But now I want to switch to our case, which was referred to our center due to cardiomegaly and tricuspid regurgitation. And these are the echo images here, which were performed at our center. And you can see here that there is a enlarged right ventricle, and you can also see the enlarged right atrium, and with a tricuspid regurgitation. And the additional fetal cardiac MRI was ordered to figure out if there is a special cause of this right ventricular dilatation. And the hypothesis of the echo report was that there was a non-compaction cardiomyopathy of the right ventricle. So we performed this fetal cardiac MRI case at a gestational age of 34 weeks. And we typically start with a survey and then do another transversal stack to look exactly for the heart position. And when we have done this, we then do our transducer placement, and we do another survey and another planning stack, this time already oriented in the axial view. And you can see here that there is there's the transducer. So on the anterior wall, and it's very good position to the fetal heart. But now we want to jump in our CNA images, and I can also enlarge this a little bit for you, that you can have a better view. And I also rotated it so that that it looks the same like in adult cardiac MRI. And we start at the apical sections of the thorax. And you can see here it's the aortic arch. So this is the pulmonary artery. You can see the ductus over there. And when we go a little bit closer to the heart, you can see that here is the left ventricular outflow tract, and there's no stenosis in this outflow tract. The left ventricle looks normal, and also the contraction of the left ventricle is normal. And what we can see in this axial view is that there is a distinct dilatation of the right ventricle, and you might have the feeling that there might be like a small diverticulum in the apex of the right ventricle, in the anterior wall of the right ventricle. And you can also see like this tricuspid regurgitation in the cine views a little bit, and also the dilated right atrium. And you can also see that due to the dilatation, and that there is also dilatation to the foramen of the left atrium. So these were the views over here, and generally, so we can also see a normal superior vena cava and a normal inferior vena cava with normal liver veins. So the anatomy of this fetus is normal, but we have this dilatation of the right ventricle. But what we don't see, and this was the suspected diagnosis in echo, that there's a non-compaction cardiomyopathy, we don't see any non-compacted myocardium. And if you look like in another view, we also did like a coronal view to look to this triangle of dysplasia to have a better view if there are some aneurysms in the right ventricular wall, which would suggest diagnosis of arrhythmogenic right ventricular cardiomyopathy. But we don't see any aneurysms in this coronal view. The only aneurysm we might see is this small outpouching, or also showed you here in the apex of the right ventricle. And then we also performed a short axis view in this fetus. We normally don't do this, but in this case, we wanted to see how is exactly the contraction pattern of the right ventricle. And if you look very carefully, you can see that there is some contraction of the right ventricle, yeah. But if you go also to the basal segments, so closer to the tricuspid valve, you can see that there is distinct hypokinesia. So the pattern is that there is in general a hypokinesia, but it's more distinct in the basal segments of the right ventricle. So the final diagnosis in this case was that this might be a right ventricular cardiomyopathy, and due to this outpouching, it might also be a sign of an RFOC. So this was our main diagnosis, but we also know that in very rare circumstances, you can also have like a myocardial infarction in fetuses. And typically this right ventricular contraction pattern where you see especially the hypokinesia in the basal segments, this would maybe also promote the differential diagnosis that there might have been a myocardial infarction. So this case, so delivery was normal in this patient. So we scanned this case roughly a month ago. I don't have a follow-up yet from this patient, also from genetic testing. But I just wanted to show you that fetal MRI can also do some differential diagnosis in cardiomyopathies. And for example, in this case, there was no non-compacted myocardium, so this is what we could rule out, and we still waiting for the genetic results and the workup of the fetus. Yeah, thank you.
Thank you, Julian. You were just saying the delivery was normal. It would have been also normal means it was a normal birth, right?
It was caesarean section, the C-section, but
I think you can
I didn't
unless you do a pig's kind of heart and then.
Sorry, here was some sound.
But there were no complications. This is what I meant. Yeah?
Okay, all right. Okay. You have shown in the MR this dilaticulum. Was that visible in the echo before, or was that only visible in the MRI?
No, this was only visible in the MRI. Yeah.
Okay.
And I also think that you can clearly see the myocardial borders there very clearly in the MRI, and that non-compaction cardiomyopathy looks different, especially if it's a genetic variant. Yeah.
Mm-hmm. Yeah, thank you so much. As you have, Julian, or did I miss a question? No. Okay, then I can ask another one. If as you are measuring quite long already and you have quite a bit of experiences, can you say how is your clinical workflow? So you have weekly patients referred to your center that you measure in the MRI. Is correct, right? How many do you measure about? Or do you scan?
Roughly, we do 1 scan per week right now. So
1 scan per week.
Bonn is a big center for congenital heart disease, and they got referred to the pediatric cardiologist and also to prenatal medicine. And if they have a suspicious finding, then they refer the case to us. Yeah. And yeah, especially like in 34 weeks of gestation, this is a typical time point where we perform the scans. Yeah.
Any recommendation, like the most learning effect or the most important thing you learned during the last years for those who are attending now the webinar and maybe have not that much experience or they are just starting? Can you comment on that? Is there anything you would recommend?
So you definitely need a learning curve for the placement of the transducer. But if you figured out how the transducer is placed right and you have a strong signal, and then I think you can just have to do it. And you have to play a little bit with your sequences and try different modes of image acquisitions, for example, with breath holding, without breath holding, and yeah, you have to figure out what works best with your system and also your workflow.
Is there anything you could say for placement of the transducer? Is there any like fact you would say that's what I learned, that's how you place it correctly? Because you can place it and you have some signal, and there are always some areas where you can't get a signal. But is there any like learning you would say this or that? So if you place it like this or that, then you have a higher chance that it works better?
So from my experience, it's always better if you derive the ultrasound signal from the anterior wall of the chest wall of the fetus. So this is what we try to do. But of course, you also have to figure out if there are some vessels, matinal vessels, and like the umbilical cord, and you should avoid to have the dust inducer placed over the umbilical cord. But yeah, I think you have to choose the most direct way, and the best way is to do it through the anterior wall of the fetal chest.
Okay, perfect. Thanks.
And one last.
Sorry, Heidi. Go ahead.
There was one question for Olga Gomez from Barcelona. She's first congratulating you for this nice images. And then regarding this diverticulum, she's asking whether you use CMR to calculate the volume or the size of it.
So, of course, for the report, we measured diverticulum like in millimeters, but in routine, we don't do volumetric analysis of the left or right ventricle right now, because we have done this in the study for the strain analysis, for example. This is where we done it, but we look for cardiac function and also sizes of the chamber. We do it visually. Yeah. So from a visual impression.
All right. Thank you very much, Julian, for sharing this.
Do we have time for one more question?
Yes, sure.
Because there's one question I just have seen to the audience also. If balance-free precession, like BTFE sequences, like CNA sequences, or spoiled gradient echo sequences, which of these two versions give the best image quality for CMR?
So we only tried BSSFP sequences for our fetuses, and I think this is also the sequences where you get the highest contrast between the myocardium and also the blood pool. There are, of course, there's a susceptibility for flow artifacts with these sequences, but I think the gain in SNR and also contrast this outweighs this disadvantages. Yeah, you can try normal graded echo sequences. We didn't do this so far, but Yeah. I don't
Okay.
know how the of the myocardium and the blood pool will be in these sequences.
Yeah. Is there anyone else who wants to comment on this once we talk about it?
Yeah, that's the same for us. We've used SSFB imaging, and I feel like whatever you're also most comfortable with on your scanner is worth trying, but we've had good success with our SSFB.
Yeah.
Us too.
Okay, perfect. So I think most of the centers I know are also using normal BTFE or SFP sequences. Okay, perfect. That one
Okay,
is
thank you
solved.
so much. So then we are jumping to Max Godfrey. Max, it's very good to have you here today as well. Max is from Sharer Zedek Medical Center in Israel. Max is pediatric cardiologist and also director of congenital cardiac image service. And yeah, Max is also sharing with us a very interesting CHD case today. So please share your screen, Max.
Okay, 1 second. All right. Can you see my slides?
See it. All right.
Perfect.
Looks good.
Okay, so thank you very much for having me. It's wonderful to be on this webinar. And the title of the webinar was, what can fetal cardiac MRI give us? What can it add to our knowledge? So I decided to rephrase that as, why bother with fetal cardiac MRI? And if we're asking that question, then we could really ask a more general question, which is, why bother with any MRI at all? Second. Why bother with cardiac MRI in general? Sorry, a little bit of slide transition issues. And I tend to think that cardiac MRI can offer us knowledge in 3 areas. And for those of us who don't have too much PTSD, we can just fly back in our memories to medical school. There were 3 main courses in the first year. That's anatomy, physiology, and pathology. And cardiac MRI has the ability to give us a lot of insights into these 3 areas of understanding the heart. Today, I'd like to talk about anatomy and pathology. I'll give 1 case of each. I won't be talking about physiology today, although, of course, there's lots to discuss in fetal physiology in fetal cardiac MRI. So first of all, we'll do an anatomy case. So this was a fetus that had a fetal echo at 22 weeks gestation, was diagnosed with double outlet right ventricle with a subpulmonary VSD. There was no outflow tract obstruction to the arteries, and there was a suspected coarctation, so the cardiologist diagnosed that this was Tausig-Bing anomaly. I have some pictures here from the fetal echo here. So on the left panel, we can see the ductal and aortic arches. We can get a sense of why they were concerned for coarctation. And on the right-hand panel, we can see a 4-chamber view sort of sweeping up to the 3-vessel view. It's a great example of some of the limitations of fetal echo, because this is clearly a moving target fetus, and it's kind of hard to get a sense of exactly how the great arteries are related to that VSD and those ventricles. So this fetus was referred for a cardiac MRI, which was performed at around 31 weeks of gestation. And here we just have effectively an axial stack going from the 4-chamber view up to the 3-vessel view. And this, I think, is if not the big advantage of fetal cardiac MRI, is that we can just take these images and slowly work our way through them and see how everything kind of hooks up to everything else. So we can just divide this stack into its component slices. Let's do that right now. And if we follow from the top left-hand panel, so we can see that we have situs solutus in terms of where the aorta is and where the IVC is. We can see moving across, we can see we have a normal 4-chambered heart with normal function. We can see pulmonary veins returning normally to the left atrium. Moving across, we can see here there's an outlet VSD. We can see that the pulmonary artery, which we see the beginnings of right here, appears to be committed to the left ventricle. Moving down to this panel here, we can see that the great vessels are detransposed, so we can see the aorta is rightwards and anterior relative to the pulmonary artery. We can also get a sense of a subaortic conus. There seems to be a ring of muscle here. We're kind of just inferior to the aortic valve right here. And as we move up to what should be the 3-vessel view, we can see a good sized transverse aortic arch. We can also see SVC, a little bit of thymus as well. And this is a left aortic arch. So we have an awful lot of anatomic information just from that one sequence. We can also try and play around with reformatting, and here we can see left ventricle, we can see the VSD right here, just under the pulmonary valve, and the pulmonary artery again seems to be directly related to the left ventricle. And this is kind of a coronal slice through the fetus, and we can see, well, we can also see the SVC in the right atrium, but we can see the pulmonary artery clearly here, and the left ventricle here. And again, the pulmonary artery seems to be directly related to the left ventricle. This is a short axis stack, which we do routinely do. Apart from being important for the imaging, it also gives us an example of some of the pitfalls of fetal cardiac MRI, because we can see that the two posterior-most slices of this stack, the fetus has moved, and we kind of move out of plane as we get towards the back of the baby. But still, we can see there's good systolic function. There are two good-sized ventricles. And we get an appreciation of the ductal and the aortic arches, which seem certainly at first view to be normal sized. And I've flipped the picture around to make it more similar to these two diagrams that honestly I've stolen from the internet. I don't remember where from, so I apologize. But these diagrams here give an impression of a normal fetal heart as opposed to a fetal heart with coarctation. And we can see that in the normal fetus, we expect the ductal and aortic arches to form a kind of continuum, that the aortic arch will be contiguous with the ductal arch in a kind of smooth structure like that. And that does seem to be the case here as well, that if this is the aortic arch here, and this posterior wall of the aortic arch seems to kind of sort of seamlessly blend into the ductal arch. Certainly didn't see an obvious shelf or figure of three on these images. So can we put our money where our mouth is? Can we make anatomical diagnoses? And I decided that on this particular study, I felt the imaging was sufficiently good quality, and I decided that we could call this that there is demalposition of the great arteries and large outlet VSD, but that the pulmonary artery seems committed to the LV, making this transposition rather than double outlet. I apologize to all the anatomic purists in the audience. I know everyone has their own definition of what is a double outlet right ventricle, but according to pretty much every definition I know, the imaging here seems to be much more consistent with TGA rather than double outlet. Certainly, I spent 2 years in Boston, and Talgeva likes to talk about whether or not a blood vessel needs to cross the VSD to get to the artery, and it does not seem to be the case in this fetus. We saw that the aorta appears remote from the VSD, the ductus arteriosus is patent and present, the left aortic arch, that there's no posterior shelf noted, and I did emphasize that coarctation can never be excluded on fetal imaging, but I felt that the risk here was lower than had previously been suspected from the fetal echo. And we see at least one right and one left-sided pulmonary vein connecting normally. And I was also able to calculate the left ventricular ejection fraction of 53%, which, although a little low for postnatal life, is perfectly normal within normal limits for fetal cardiac MRI. I believe that data was presented at one of the earlier webinars. So again, a lot of anatomic definition with actually just a few cine stacks. And now I'd like to move on to a pathology case. So this is fetal echo was performed at week 25. They'd been referred due to echogenic foci. And the cardiologist who performed the scan suspected that there was a small rhabdomyoma in an otherwise normal heart. So again, we have some images from the fetal echo right here, and we can see that there's this somewhat larger than we would normally expect for an echogenic focus. It's got a bigger and more irregular looking finding here at kind of the anterosuperior interventricular septum here on the left ventricular side. We can see it in both of these panels. And I thought this would be a good opportunity to test out our cardiac MRI scanner. I probably should have mentioned earlier, we're also using Siemens 1.5 Tesla, and we have the SmartSync device. And before going ahead and scanning, we need to know what would a rhabdomyoma look like on MRI. So rhabdomyomas are normally considered to be homogeneous on all sequences, and relevant to us, they are mildly hyperintense on T2 and isointense the myocardium on T1 sequences. And although, as far as I can tell, there's no data on this in the fetus, I decided to go ahead and give it a shot. So we can see here on the standard cine imaging, 4-chamber and short axis, this is a structurally normal heart. We can see full chambered heart, crossing outflows, normal 3-vessel view, left aortic arch, and on short axis, we see excellent function. There is this little finding right here, which honestly, had I not known of the fetal echo, I may have just considered this to be an accessory papillary muscle. So we went ahead and tried to do some tissue characterization. The quality is not amazing, but there is possibly this area here of kind of fuzziness on T1, which looks, I think, roughly the same area that this finding would be, and it would be more or less the same kind of intensity as the surrounding myocardium. I would accept that it's not terribly convincing. The T2 imaging, however, was a little more convincing on the short axis. Again, the long axis wasn't very revealing, but we do have this kind of bright area here on the short axis on the T2 weighted imaging. There's an arrow here, so it must be true, pointing to where this finding is, and I've tried to put rearrange the orientation of the fetal echo to kind of get a sense of where that finding was here and here, and it kind of is roughly the same area that we have this kind of echo bright, sorry, hyper intense, and not an echo anymore, hyper intense MRI finding right here. I wouldn't want to swear to this. I do think firmly that tissue characterization of the fetus should be taken with a hefty dose of salt, a big pinch of salt. I don't think we're there just yet, but I would say in my defense that on the postnatal echo, that there was indeed a suspected rhabdomyoma. No postnatal MRI was performed, but this finding did reportedly spontaneously regress over a period of a few months, which would be consistent with a natural history of a rhabdomyoma. The baby was genetically and clinically negative for tuberous sclerosis, and single isolated rhabdomyoma tend to be less associated with tuberous sclerosis. So my take-home messages are that fetal cardiac MRI can provide excellent anatomical detail, and we have the advantage of the kind of multiple slice, sort of patiently building up stack slice by slice, so we have the understanding of the anatomy of the whole stack. And I think that certainly, at least on a proof of concept level, tissue characterization can be performed, but the sequences need a lot of tweaking. I don't think we're there yet, but it's certainly something to aim for. Thank you very much.
Thank you a lot. Thanks a lot, Max, for this very nice illustration. The second case you've shown was 30 plus 5 weeks. So do you usually start? I would say it's completely okay to start with 30 weeks, but did you also scan earlier cases, or you start with 30 weeks, or do you follow up them later as well?
So thanks, that's a great question. We've typically found that our imaging is much better the nearer you get to 30. We did a couple of week 24, week 22, and honestly, it was a disaster. The fetal motion is, baby just moves too much. You can't really kind of get a handle on things. From around, we've done, I think, week 28 and done reasonably well. Week 13 onwards is when we get our better imaging. What we tend to do, just to touch on something that was mentioned earlier, I actually, before the woman goes into the scanner, I take an ultrasound probe and just look at where the fetal heart would be nearest to the surface, and I make a little mark with a pen on her abdomen where I find the fetal heart to be nearest the surface, where I think we're likely to get best signal. Then the technician goes ahead, puts the device on the abdomen, and like I say, week 30 and upwards is where I find that we're getting our best imaging.
All right. Thank you so much for this explanation, Max. So there are some questions. Let me see. Mansi Gatondi from Dallas. That's correct, yeah. How much time did you feel it took you to get diagnostic visualization of the mass for T1 and T2 weighted imaging, especially with fetal motion? Did you have to repeat the sequences more than expected?
Probably the answer is yes, because we repeat a lot of sequences a lot of the time. I don't remember the specifics. I remember that we tried to also do true mapping sequences, and they failed miserably. Didn't work at all. I don't remember that we did too many repeated scans, but we have 2 or 3 projections for each for the T1 and the T2. I think we need to work more on the quality, to be honest. Like you saw, it's not crisp enough.
One question because I think the tissue characterization is a very, very good thing that fetal MRI can do, but I think there are not too many people that have really tried it and are working on this. But for the sequences itself, the acquisition window that you would have for this prospective scans, did you adapt them, or did you just take the one that you have for adults?
We took our stock scan that we used. Okay. I would imagine it was our pediatric scan. Unfortunately, my technician isn't here with me right now. He's the brains behind this. But from memory, we took the regular scan and tweaked the parameters a little bit just to get better imaging.
Yeah, sweet.
But I can, if we can correspond on the more technical details.
Yeah, I think it will be really interesting, especially what kind of trigger we can use, because we can switch between this backward and forward trigger, which have different timings, and then it would be this could also impact the quality, actually.
Right. I think, to be honest, he thought I was crazy to say, go ahead and try T1, T2.
It's super crazy. Yeah, I love it. I love it. That's why I'm already thinking, like, how can we do this? I like it.
But like I say, I was pleasantly surprised. I expected nothing at all. Like I say, the mapping gave me nothing at all. But the stir and the term and the things like that just gave me images that I thought we could work with. If the baby had been born and had not had a rhabdomyoma, then I'd feel a little foolish. I have the advantage that the first baby hasn't been born yet, so I don't know if it's TGA or double outlet. But the second baby has been born, did have what appears to appear to be a rhabdomyoma. There is that finding on the short axon T2. It is what it is. I wouldn't want to put too much.
No, it's really good. But I think let's exchange on this to see if we can help in getting this done. I think it's really good. There's one more question from Sohail from the UCLA. If someone used fetal MRI on 0.55, like a low field MRI, if someone has experience with that so far, I think no one right now.
No. I think it's mainly research. I know these papers, so if you look at the images in these papers, and you always do your best images in these papers, I don't think they look amazing, So I think this is a mainly research question right now.
So what we can say for that is that we have tested the ultrasound probe for that feed strength, and it works. And we have a plan to also put the CE mark on this feed strength to get the gating working on that feed strength to support that. But this is somewhere in the future, let's say half a year or something, where we can add this to that feed strength.
There was one more question, I think for everybody, not just for Max, but everybody can answer who wants, from Ramdani. He's asking, because noise, of course, is a drawback to all images in the CMR, also those we just saw, whether you think that AI would improve image quality and will not influence calculations of volume cavities. Is there anybody who wants to answer to this? Very interesting questions. Max, you're smiling.
AI in acquisition or AI in analysis? That's two very different. I'm assuming you mean in analysis.
Ramdani, you can also talk if you want, and just unmute yourself if you want to add something to the question.
I'll just go.
Hello, everyone.
Oh, sorry.
Hello, everyone.
Hello.
I mean AI in acquisition. That's what I mean.
I have no experience with that. It sounds like a very interesting field of research. I have some, I'm sure most people here, the software program that we use for interpretation uses a lot of AI in its volumetric analysis, and its true machine learning gets better and better, and I have to tweak less and less, certainly the left ventricle. Right ventricle is always a challenge. I don't know that anyone has experience with AI in acquisition, and that's a super interesting question.
So we have.
It's currently most used. It's in image reconstruction, right? So not so much in acquisition, but in image reconstruction. We can see this across all vendors: Siemens, Philips, They all have their AI denoising reconstructions and also upscaling reconstruction of image resolution. And of course, if you look like for images like MSK or brain images, it looks very good. So the images are sharper, you have less noise. And of course, you can also adapt these sequences to cardiac MRI and also to fetal cardiac MRI. And this is, for example, we did this also at our site. And what we can see is that with denoising and also like such super res reconstructions, you can get sharper images and also images with a higher SNR. So I think this will be an interesting new field also for fetal cardiac MRI. And yeah, we have to look how the images look with the vendor specific algorithms. Yeah, you have to figure it out, but it works, and results are quite good, I would say.
Thank you, Julian, for this. I was just reading the chat. Thiago was commenting on Sohail's comment regarding 0.55 Tesla. Yeah, thank you. That's interesting. If you want to add something, Thiago, you can also speak up and unmute yourself. You're welcome. If not, we would jump to our last presentation. Okay, now there was another question regarding low field from Diana related to low field topic. Is there a preference for 1.5 Tesla or 3 Tesla for fetal imaging? Diana from Philips. Who wants to answer?
I was just wondering from the presenters if they have a specific preference.
I'll just speak. Working on the 1.5 is our only experience right now, and I think there's advantages to a 3 Tesla increased signal, but I think whatever you have and can utilize, either one has its advantages. So I think we've had good success on the 1.5, but certainly there's advantages to using a 3 Tesla as well.
Joshua, do you want to comment on that?
Sure, yeah, I can comment on all 3 field strengths, if that's helpful, because I've done fetal cardiac MR at 0.55, 1.5, and 3. And you are essentially fighting against or gaining signal to noise, going to a higher field strength, and fighting against field inhomogeneities and artifacts that arise from that. So at low field strengths, you're doing quite well with a balanced SSFP sequence, for example, along with reduced SAR and acoustic noise, things like that. So the comfort gets higher, and at least our collaborators at USC and from what I've heard talking to people at KCL, with optimized sequences, you can do a quite comprehensive fetal MR protocol at the low field. But if you did want to do fetal neuro, for example, if you want to do non-SSFP fetal CMR, a higher field strength, 1.5 is, I think, typical, but 3T could be quite advantageous there. So it depends on the specific type of sequence that you want to go for.
Thank you so much, Joshua, for sharing this experience. Just very quickly, regarding 7T, is it unsafe for the fetus? That was another question. Anybody wants to comment on that, or?
From what I know, yes, and I think no one would have done it yet. So, and I would say that they don't fit into the bore as well. So
yeah, so small.
It's either just several reasons. So it's too small, but it's also I would say not safe for the woman and baby.
Yeah, the guidelines recommend to go up to 3 Tesla, and that's it.
Yeah, exactly.
Maybe another comment to this is what Joshua just said. So regarding the field strength, I think you can do good images on 1.5 Tesla as well. But if you look for specific sequences, like for example 4D flow, I think there you have a great advantage with higher field strength. So this is at least my experience that you have a gain in SNR there.
All right, we jump to the last presentation, to the last clinical case today. It is Mark Huppertz. Welcome, very welcome. Mark, nice that you are here from University Hospital of Aachen in Germany. Mark is radiologist and is also sharing an interesting case. Very welcome. You can share your slides, Mark. And we can see it.
Perfect.
It's perfect, yeah.
So thank you very much for having me. I'm really excited to show a case here today. I will talk about fetus with hypoplastic left heart syndrome. Yeah, we'll jump right into it. It was a fetus that came to our site at week 32, was diagnosed with hypoplastic left heart syndrome via echocardiography. And it was proposed to a site by external cardiologist. It was diagnosed in the 24th week, but nothing was done in the time to the 32 when the patient came to us. So the pediatric cardiologist at our site performed an echo and had the suspicion of a premature closure of the foramen ovale. And so just a short overview, hypoplastic left heart syndrome. I think we know. I just rush a bit up because time is flowing. Yeah, typically blood flow is returned via foramen ovale and the ductus. And if you have restricted or closure of the foramen ovale, it can, lead to atrial restriction and lead to a bad prognosis for the fetus. And so with this suspicion, we went further in diagnostic. We looked at the pulmonary lungs, just the echo from step 1, see the small left-sided heart. Here we see the intact septum and with no real flow, just a little bit. So the suspicion of the closure of the foramen ovale, and here the Doppler measurement of the lung vein showing arterialization and reduced VTI. So suspicion for atrial restriction and bad prognosis for the fetus. So additionally, the ascending aorta wasn't easy to see in the echocardiography. So there was just these apical views where there was small aortic arch and suspected retrograde flow. This was the second finding in the echocardiography. So the case was in total a bit unclear. Especially question to the MRI was, do we have really closed foramen ovale? Is there any sign of restriction? Can we see lung damage to estimate the prognosis of the fetus, to see if there's indication for emergency operation or intervention after, or even prenatal intervention before birth to prevent lung damage, for example, and how to handle the case in advance. Yeah, so here we see the axial images of this case from cranial to caudal. Might be a bit small. We will go through them just image by image. So here we come from upside, go to the next one. We see, no, it's not moving. Okay, we see this small arch here, the supraaorta vessels. Then here we see the ductal arch. When we go further, we don't see the ascending aorta in this point. There's very less signal in the left-sided heart. We will see this here on the left side here. The pulmonary arteries, they are very small. The duct is pretty strong. And now when we go a little bit down, we see very low signal in the left-sided small heart. We see very dilated lung vein, also here on this plane. And yeah, we see that the atrial septum is completely intact. We see no foramen ovale, and we see no jet between the right and the left atrium. And I'll jump past this. Okay. So yeah, so the first thing we could see was the intact septum. So no jet, no visual sign of open foramen ovale, so there might be closure. Then we went further, made 4D flow and reconstructed it axial in this plane of the four-chamber view, and see no real flow inside of the left atrium. We see no flow to the right atrium at this point. I tried to overlay it here. So you might see there's a bit flow in the left ventricle, right atrium, and in the aorta, but nearly no flow. So restriction of the left atrium and the dilated lung veins. Here we see overview over the 4D flow. And if you look into it a bit, you might see just a little nose here on the left side of the duct. You see here the duct arch, but you cannot see a significant flow of the ascending aorta or the left heart at all. So if we head on, yeah, we can see here small arch, but just, yeah, maybe or maybe not a little bit retrograde flow. You see here the duct is showing flow, and a little bit afterward you see this nose, which you could see in the 3D reconstruction before. The slice is a bit between this slice and this slice, so you maybe have a bit of this arch and a bit of this duct arch. But there's maybe a hypoplastic arch, and the ascending aorta does not show any relevant antegrade flow. Maybe there's a bit retrograde flow in the arch or in the distal ascending aorta. Yeah, here again the 4D flow and sagittal sequence where we can follow the duct and the ductal arch, but see no relevant flow from the aorta. And now the most important, or the final question to us, is there any lung damage yet in this patient? Is there bad prognosis or indication to prenatal intervention? Yeah, so we see nutmeg lung. What this means is this pattern we see here, like in a cut nutmeg, where you can see lymphangiectasis or lymphangiotasia, sorry, and dilated pulmonary veins from the atrial restriction, and the blood that is pressed back into the lung, which leads to chronic lung damage and lung fibrosis. So with this image, you see here very much or very strong lymphangiectasia and lung structure damage. So this is a very bad prognosis. The fetus with these images may not be very likely to live long enough to see procedures like correction operation to enhance life, and so there was no indication to prenatal intervention because the lung damage was already present at this point. Yeah. So in conclusion, why is the MRI important? We can see anatomical and functional details that may complete the echocardiography. So for once we may see things we don't see in the echo, and for the other point is we may see things that we think we see in echo but are not completely sure. So we have a second different imaging that can confirm suspicions in the echocardiography and help making decisions, especially in prenatal planning and intervention, but also for birth planning and planning of emergency operation or intervention. Yeah. Thank you very much.
Thank you very much. I was wondering, when I saw the actual stack of the MRI images, did you do that in breath hold or was it free breathing?
That was breath hold.
Breath hold, okay.
For how long?
Acquisition
time, more or less.
The breath hold was about, let me think, 9 to 12 seconds. And depending on how much slices, so 1 breath hold per slice.
Yes, Julian, please.
Oh, this was just an error. Sorry.
Okay. When you were saying the confirmation of the foramen ovale, you said it might be closed. That was one question you had, and then you saw the MRI images and you said it might be closed. Does that mean it's still a chance that it's not closed, right? So you are not really sure after you did the MRI, or?
So after the MRI in confirmation in completion with the echocardiography, we're pretty sure it's closed.
Right. Okay.
There was the question if there's just a small, very, very small rest, but the MRI shows no sign of any flow over the septum, so we're pretty sure it's closed.
Right.
But at this point of lung damage, it does not really matter anymore.
All right. Okay. Is there any other question? Otherwise, we are at the very end now. Thank you so much for all your presentations. I'm just sharing my slide for the last time, and probably some left already, but I would love to, again, for those who have entered later this webinar session, just a short reminder again that we have a forum now online, so north.de, and you can make some notes, ask questions, just get into communication, get into exchange. This would, I think would help the whole community to just have an opportunity to exchange. I would be happy if you use it. And I would like to thank for your support and for your attendance. Of course, I would like to thank the Society for Cardiovascular Magnetic Resonance for the support, also to sharing this webinar information. It's increasing, and I think we are a very good community right now, the Fetal Heart Society as well. And I would like you to see in December. This is our next webinar session. It's the 11th of September, again, a Wednesday. I'm happy to see you all there. Thank you very much for attention.
One more comment.
Yeah.
I just have seen from Leonard Suchat from Illinois. For the US people, please write an email. She's trying to get a CPT code and needs all your support. I think this is the perfect platform to help with this and to connect. So in the chat, there is her email, and reach out to her for this big effort to get this reimbursed.
Great. Eleanor, now I also have to add something. If you want, you can now say a few words about the status, because I was asked by many people what the status is. If you like, you can say a few sentences. I think this is of high interest for many people here. If not, we might shift it to the next webinar session as a special topic. I think that would be good.
Of course. I will be brief. The process to create a new CPT code for billing in the US is a lengthy one. We would be starting out with a Category 3 code. I've been discussing this process with the advocacy committee within SCMR. And in order to build an application, we need examples of clinical cases where the specific fetal CMR piece has been useful and changed the management long term. And I think that's it for now.
Thank you very much. All right. Thank you all. Have a good day. Bye-bye.
Thanks so much, everyone.
Bye. Thanks so much.
Great cases.
Bye. Thank you.
Thank
Bye,
you.
thank you.
Thank you.
Bye.
Bye.